All right, good evening, everyone. Thank you for joining us this evening. On behalf of Telix Pharmaceuticals, we're very happy to have you here. This is new and exciting. Finally, there's actually something very new for the imaging of glioblastoma. So with us today, and take your time as you get through the lines, we'll just continue with the process and the content and the presentation. I want to point out a couple of things. We have our medical director for brain imaging, and that's Nabil El-Shafei. He'll be here to answer some questions. Our primary presenter tonight is Jonathan McConathy, who you can see is Professor of Radiology and the Director of Molecular Imaging and Therapeutics at UAB. This content is obviously pre-launch of FET PET for glio. This program will be recorded. After the presentation, we'll be able to take some questions. We have a couple of mics here, and we'll be able to kind of rove through the audience, and feel free to ask questions. So let's welcome to the stage Dr. Jonathan McConathy.
Thank you, Esteban, and thanks all of you for coming. So without further ado, we're going to be, as you might have guessed, talking about clinical interpretation of FET PET for gliomas. This is a non-promotional educational presentation for scientific exchange. This is for your use. It's a product that's not yet approved, and so to some degree we're using what we think is going to be the interpretation criteria. Here's some additional disclosures, and really Telix is the primary one that's important. In general, I think it's an exciting time for neuro-oncology. We're obviously going to be focused on gliomas and FET. There are some other amino acids out there that have been used as well. Meningiomas are exciting with somatostatin receptor imaging and potentially therapy, as well as brain metastases. And just in general, there's so much progress and so much more either availability or near clinical availability of tracers, at least in the United States, that I think we're going to see a big change in the way we diagnose and subsequently treat brain tumors. A very common theme, and that's going to be a big theme of my presentation, is when we see an equivocal lesion on MRI, are we dealing with recurrent or progressive glioma, or are we dealing with a treatment effect that mimics progression on MR? And it's really important for patients and for treating physicians to get this right. So in terms of FET, it's a derivative of tyrosine. So basically the Fe is the fluoroethyl part of FET. That's where the label is. By making this change, it's metabolically stable in humans, so it really just undergoes transport. One of the real benefits of FET over a lot of very effective oncology agents in general is FET crosses the normal blood-brain barrier. And so there's transporters that will get FET into the normal brain. That's important because the FET can access the entire tumor volume and can show non-enhancing tumor. There's extensive clinical and research use in Europe, Australia, and Asia, now more in the United States as well. And in general, numerous studies have shown that FET is superior to MR alone and superior to FDG for evaluating recurrent glioma. So a little more about the transport. System L is large neutral amino acids, so tyrosine, phenylalanine, leucine, tryptophan. It's an established target for brain tumor imaging. And one of the transporters, called LAT1, is overexpressed in many tumors, including gliomas. As I mentioned earlier, because it crosses the blood-brain barrier, you can get to the entire tumor volume. And one of the things to know about FET and similar tracers is the transporters either are exchangers, so when amino acid goes into the cell, an amino acid needs to leave, or facilitated diffusers that just make it possible for the polar amino acid to get across the cell surface. The main point is there's not a concentrative mechanism, so you can see washout over time from some tumors, and so the timing of imaging can be important because of these mechanisms of transport. Here are just some examples of the structures, and again, we're focused on FET. How is FET typically performed in a clinical setting? Generally, there's a request for patients to fast for 4 hours before injection. Unlike FDG and other glucose analogs, there's not a big insulin effect. The main concern is if there's high amino acid levels in the serum and the plasma, that it could compete for transport across the blood-brain barrier. But in general, fasting has much of and eating before a study seems to have much less of an effect. But again, just to be as consistent as possible, 4 hours of fasting is recommended. Typical injection amounts are going to be 5 to 10 millicuries. Could be potentially lower if you have a very high sensitivity scanner, but these are, if you look in the literature, typical activities. The key time point seems the best time point for imaging gliomas is typically 20 to 40 minutes after injection. By going out 20 minutes, you've allowed some of the blood pool to clear, but you've not allowed for substantial washout. Some centers do dynamic imaging, and you potentially could do that because you just need to image for 40 minutes. But in general, most of the data is really focused on static time points, and presumably that's going to be the major way of doing this in the clinical setting. And then at the end of the study, like many PET tracers, have the patient void to reduce bladder dose. This is from an older publication, but it's still true, looking at the potential uses of amino acid PET in glioma. And really, there's good data from the time of suspicious lesion all the way through biopsy or surgical resection, evaluation or planning for radiotherapy, measuring response, and following up. A lot of the use we anticipate is going to be in the setting of distinguishing recurrent or progressive glioma from treatment effect. So some things about the metrics of interpreting FET PET. If you read FDG PET, you're familiar with SUVs. So this is essentially a concentration that you've normalized for patient weight and injected activity. We might have a mean, maximum, peak SUV inside a volume of interest. So if I draw, hopefully you can nicely see this magenta outline. This is just an initial region of interest. And when later in the presentation, I'm going to show you how we do this in a real simulated clinical setting. We typically will draw an initial ROI. Within that, there's going to be an SUV max. And so for a lot of FDG body oncology, we measure that all the time. So we get an SUV mean and a maximum SUV. Those are important, but in general for FET PET, those haven't been great parameters. So using SUV values by themselves hasn't been very effective. So what we instead is use tumor to brain ratios, which are based on SUVs. But the difference is we have the SUV in the tumor as well as an SUV in a normal brain reference region. And so it's a ratio of your lesion to the reference region. And then we use TBR thresholds. And I'll go through this to make it clear, but we use these thresholds either visually or quantitatively to determine whether or not this exceeds a threshold to be considered positive. And so some of the key thresholds that have been reported in the literature and seem pretty consistent across publications are in untreated glioma, TBR 1.6, so 1.6-fold higher than the reference region, is used to define the tumor volume. Whereas TBR 2.3, because there is some increased uptake associated with treatment effects, we use a higher threshold to distinguish recurrent or progressive glioma from treatment effects. And so, like a lot of things in medicine where we use quantitation, certainly in imaging, it's important, but it shouldn't override your clinical judgment. And there can be technical errors, patient or treatment factors that could influence. So these are really important, but it's not as if you know the TBR, you definitely know the answer. You need to put the whole picture together and keep your eye open for errors or potential confounds. So the typical way to draw a reference region, and again, I'll demonstrate this later in the presentation, is a crescentic or banana-shaped region of interest, typically over the contralateral brain. So I think of drawing it over the cortex, but really you're not trying to exclude white matter, and you just want to do your best to avoid an area that's abnormal, either involved with tumor or if there was some other abnormality there. And so here we have our reference region in cyan and magenta for the initial VOI. And so we can provide our reference region SUVs, and we're going to be using those to calculate TBRs. I'm showing this, how these are calculated, just so you think about how it's actually done and if you need to troubleshoot. But in reality, in your practice, you're going to want to use a workflow, and I'll show you an example of a workflow that does this automatically for you. So, hopefully you're not there with a pencil or paper or a calculator calculating this. But if you don't understand what's going on, you're going to not be able to troubleshoot. You may not recognize errors. And so, TBR 1.6 is simply the reference SUV mean times 1.6. So anything with an SUV value above 3.01 in an untreated glioma would be considered part of the glioma volume. If you're looking for treatment effect versus true viable tumor tissue, we use this higher ratio of 2.3. So we have a higher SUV threshold. So anything for this reference region, anything with an SUV over 4.32 would be considered positive for viable tumor. Just showing the histogram. So, this is the initial ROI in magenta. You can see this purple 1.6 TBR and then this red TBR 2.3. And we're basically just taking voxel or pixel values above 1.6 or 2.3 tumor to brain ratios. Other things you may see, and probably of these, the ones that are most important are biological tumor volume. You may also see this called metabolic tumor volume. These tumor volumes can have important prognostic information. If you're following response, the change in tumor volume may actually be a better indicator of response than the change in TBRs or changes in SUVs. So you may see this in the literature. Total lesional activity hasn't really made it into routine use. You may see that as well, but in addition to TBR, you may see BTV. So let's kind of talk step by step and go through how we would interpret a typical FET PET. Obviously, you want to load it. But you also, if at all possible, if you're doing PET CT, you want to load a prior MR. I'm not going to say it's impossible to interpret these without MR, but I really think to do this at a high level, you want to have an MR, at least the key sequences, and we'll talk about that in a minute. You want to fuse those, the PET and the MR, and then you'll draw a reference region. And so let's look at these first two steps. I'm not trying to make you neuroradiologists, but I think kind of the minimum group of images you want to have are a pre-contrast T1, a post-contrast T1. And so when we talk about enhancing lesions, we're really talking about things that enhance on post-contrast, and a T2 flare image. Those are kind of, to me, the core MR sequences you'd like to have when you interpret FET PET. And I showed this case. This isn't a brain. This is more to show just some of the properties of MR. Here is an area that's bright on T1 pre-contrast because there's blood after a procedure. That doesn't really change after contrast, but we see this new area that wasn't there on the pre, so we know that's an enhancing lesion. T2 flare is somewhat nonspecific. It's typically going to be larger than your enhancing lesion. Some of that's going to be tumor. Some of that may be treatment effect if there's been prior treatment. Some of that may be edema or other things that aren't actually gross tumor. Some other nice to have sequences are diffusion weighted imaging, which is bright when you have restricted diffusion. Things that restrict diffusion in terms of tumors are typically cellularity. This person actually had a peri-procedural infarct. To prove that it's actually diffusion restriction, you need to have this apparent diffusion coefficient map where bright on diffusion, dark on ADC. Again, this isn't something you're going to be used primarily for your FET interpretation, but it's helpful because if you're dealing with a tumor that it's very cellular, often it will restrict diffusion, and that might help you shade your interpretation of FET. And T2 is similar to FLAIR. The main difference is you can see CSF. FLAIR in some parts of the brain, particularly the posterior fossa, can have some artifacts. So T2 can help you if you think you might have an artifact on FLAIR. So again, I'm not generally your neuroradiology colleagues, unless you're a neuroradiologist, are going to be interpreting it, but I think having those and understanding the basics of MR are important. Then we want to draw our reference region. And so the typical method is a 15 millimeter diameter circular drawing tool is what people use to draw this crescentic or banana-shaped volume of interest. Typically 3 consecutive slices, and people have done studies showing that different readers will get very consistent reference SUVs using this method. So it actually works pretty well. And again, you want to draw it on what appears to be normal brain, if possible, contralateral to the side of the tumor. And this is kind of where it gets a little different than what you might be used to, and this is really important for interpreting this correctly. Most people, when they do the qualitative interpretation of FET PET, are going to use a color scale, and we're all familiar with color scales, but the key is you want to adjust your color scale so you know where the transition is above your TBR threshold. So let me show you what that looks like. This is the Sokolov scale. So the folks at ULICH who've done a lot of the work with FET insist that this is the best scale. You can use what you know to be the best scale. Everyone has an opinion about what the best scale is. But this is a good example, and I'll show you how it works. It's really important to set this correctly. Otherwise, you could misinterpret the study. And again, I'm going to show you how a workflow can do that automatically, so you're not doing this manually. But again, understanding what goes into it's going to help you troubleshoot and avoid errors. And really what we want to do is have a 0 lower limit value, which is typical of PET, and we want to set this upper limit value to a specific number that's going to have our transition of color at a place where we know it's going to be easy to see. And that's really the key for any scale you use. It needs to be clear where the transition is. So coming back to the case we had this TBR of 1.6 based on the reference region of a transition value of 3.01. And so it turns out on this scale, we can have a transition right here kind of from cyan to green by setting the upper limit value as twice the transition value. And so by doing this, if I look at images and I see green, yellow, orange, red higher than the cyan, I know we're over TBR 1.6. It also turns out that the upper limit value, the TBR 2.3 transition is between yellow and orange. So in one image, one color scale, you can see, are you over 1.6? Are you over 2.3? You can also set this differently, and I show this because you need to know how the color scale was set. We could also set the transition to be cyan to green for TBR 2.3 by changing this upper limit value. And again, if you're in the reading room doing this by hand or with a calculator, you're probably not doing it right. You need to use a workflow. But the point is, you can have the exact same color scale, but if you don't know how it was set, or if you didn't set it yourself, you could misinterpret. So it's important to understand what color scale you're working with and where the transitions are. So let's kind of see what this looks like. So here's a case that's obviously positive. Green is going to be TBR 1.6. And so we can see that most of this is well over green, corresponding to this enhancing lesion. And if we look at a region of interest or a volume of interest that outlines TBR 1.6, again, you can see things that are green, yellow, and higher are in this TBR 1.6. If we look at, using this scale above TBR 2.3 is going to be orange or higher, so we're up in this part. And if we look at the region that is outlined for TBR 2.3, we can see that we're in the oranges, reds, and whites. And I actually also like having, and you'll see the workflow has these volumes of interest, and that's a way to kind of double check yourself and know that really what are you dealing with in terms of the TBR of a region of interest. This is something that you can do also. You don't have to do it. I like doing it. I think it also can make nice presentations. This is something, and I'll show you in some cases in a moment, is to actually bring the lower threshold of your scale up to the TBR you want. And this can be nice for looking at fusion images. If you had to interpret one of these in a setting where maybe you didn't have your workflow, you might have to get out your piece of paper or calculator, but this is a way to do it that will work. And so the idea is to set the lower limit at the threshold. And so let's think of a TBR 2.3. We want anything over an SUV of 4.32 to be considered tumor. So instead of a 0 lower limit, we want to set that to 4.32. It's not magic that you could choose another number. I typically like to use twice this lower limit value to have a reasonable dynamic range for FET. But if you make it too high, it can make things faint. If you make it too low, everything's going to be too intense. And so what this looks like is we have our case here. When I threshold, so here we have set as the TBR 1.6 threshold and the TBR 2.3 threshold, different color scales. But when I bring the lower limit up to 1.6, you can see I only see PET signal that's above that 1.6 TBR. If I go up to TBR 2.3, I only see PET signal above the TBR 2.3. And this shows up nicely on the fusion images as well. So that's another way to display the images. In the workflow I show you, that's an option. You don't have to do it, but it can help you, particularly if you're trying to show on an MR where the areas that are positive based on FET PET are present. You don't have to draw volumes of interest. I find them very helpful. I think in a lot of practices, the neurosurgeon or radiation oncologist maybe less because they may do it themselves, but may be interested in you providing a region of interest that shows the boundaries of what's considered positive. And so this, you've seen this before, from an initial volume of interest, we can set the appropriate thresholds to make subthresholds. So here's our TBR 1.6, and in red's our TBR 2.3. And many viewers will allow you to make this, save it, potentially make screen captures or CNAs for your referring clinicians to use. You do want to review the images qualitatively. So like I said, the quantitation is important both in terms of setting the color scale and thinking about thresholds, but you do want to look at the images critically. Again, numbers and thresholds are very helpful, but you don't want to let that override your clinical judgment or particularities about a case. And so some of the quantitative things that are used in addition to these thresholds are 16 millimeter circle that's centered at the SUV max of the tumor or lesion volume of interest. And you can use that to calculate what's called TBR max. And so let's look at that. So here we have our TBR 2.3 again, and within that we have our SUV max. And at that SUV max, the workflow can place a 16 millimeter diameter circle. The two-dimensional circle is then used to measure an SUV, and dividing that by your reference region is going to give our TBR max. When you look at the literature, and this is very important and can be confusing, you'll see TBR max, you'll see TBR mean. Make sure you understand in that publication how they calculated it. This has been a very common way. It's not the only way to do it, but this is a way to calculate TBR max. And just like I was saying, the TBR 2.3 threshold, generally a TBR max over 2.3 is going to be considered positive for tumor. But there are some pitfalls with it. And so, again, you don't want to be stuck on one number basing your entire interpretation based on that. So in general, FET PET, while not perfect, does have good performance. So roughly 90% sensitivity and specificity, particularly for distinguishing high-grade glioma from treatment effect. Different publications and different scenarios may give you slightly different numbers, but that's approximately correct. Higher tumor to brain ratios, larger biological tumor volumes. If you do dynamic imaging, quick peak uptake in the lesion are all associated with worse prognosis. And one thing to keep in mind, while I think there's been a lot of good efforts, there is some issues with standardization, particularly limited multi-center studies. So again, while these thresholds are well validated, they are not, gospel. They're not the absolute truth. You need to be careful, but they're very good guidelines. Some things to be aware of. While FET works well in low-grade gliomas and actually has a nice role for evaluating non-enhancing gliomas and showing volumes, it is the case that roughly 20 to 30% of low-grade gliomas have either low or no FET uptake. So these can be negative on FET PET. There are examples and reports of non-neoplastic lesions with higher FET uptake than normal brain. So high FET uptake does not automatically mean tumor. This can be treatment-related inflammation. And again, that's one of the reasons we bring the TBR up. There have been reports of increased FET uptake in stroke or ischemic brain, which can happen after procedures and surgery, abscesses, and actually epileptic foci. Usually these are mild, but they are confounds, and so we shouldn't think of FET PET higher than normal brain as synonymous with tumor. Another issue that we run into all the time is we kind of think of these as, we sometimes think of this or describe it as binary. It's either tumor or it's treatment effect. The reality is if you look at the pathology, often it's a mixture of treated tumor and viable tumor. And so some of those may not meet the threshold for criteria, particularly if it's a relatively small percentage of viable tumor in a large amount of treatment effect. Another thing with FET in particular, just be aware of, especially if you're early after injection, there is substantial activity in the blood, and you're going to see these in the venous sinuses, the sagittal sinus, the transverse sinuses in particular. So when you draw your regions of interest, your volume, if you're measuring volumes or things like that, just be careful, use the MR to make sure you haven't included a vascular structure in it. That's usually easy to do, but if you're not paying attention, it's also easy to accidentally include it. So in terms of what you want to report, that's going to depend a little bit on the scenario, but here's some general guidance. Obviously, you want to say, do you think it's positive or negative for viable glioma? There are going to be some equivocal studies. We'll look at a couple of studies that different, competent readers might read differently. And that's okay to express. You don't want to call everything equivocal. So try to give your best evaluation whether you see evidence of glioma or not. I think, it's going to depend a little bit on your audience and how much they want to know. If they're very familiar with viewing images themselves, this may not be super important. But I think it is important to talk about the distribution of FET relative to contrast enhancement and flare. Typically, you're going to see a larger area of brain involved based on FET compared to contrast. But you also may see contrast-enhancing lesions without uptake, and that's important because those are likely treatment effect. And so giving some sense of the overlap is important, particularly if someone's thinking about biopsying or thinking about resection. Similarly, FET is often similar to flare, but can be different. You may see areas that extend outside of flare hyperintensity, but often the volume is a little bit smaller than the flare hyperintensity. You don't necessarily need to describe this in great detail, but if there's big discrepancies, if there's a large amount of non-enhancing glioma, you want to include that in your report. And if people really need detailed information, that's one of the reasons these volumes of interest can be very helpful. And many viewers can export these as RT structures, which could be then used in other systems. TBR max you'd like to report, and consider reporting biological tumor volume. So now we're going to shift over and look at some cases. Oh, we're still logged in. Good. So this is an example. This is a case from UAB. It was a 73-year-old woman as part of a clinical trial who had a right frontal glioblastoma. It was resected. She had chemoradiation. We performed this a little earlier than you might normally do. This was 4 weeks after completing chemoradiation. So let me switch over to MIM. So, there are a number of viewers out there that can be used. I'm going to show you a workflow in MIM that I find quite effective. In general, I think if you're going to be interpreting these cases, you want to have a workflow that you understand and like to do all of the setting color scales, drawing things at the appropriate threshold. Otherwise, this could take a long time to interpret and would be prone to error. So I'm going to launch this workflow. What I'm loading here is our FET, as well as some selected MR sequences that I find helpful. So this is just showing they match. Sometimes, and you'll see some examples here, if MIM doesn't recognize the name, I might have to switch out. So what this is doing is loading the images. And on the left, each of these little cells or buttons is a workflow. And so it looks a little bit busy. This can be customized. You might find that you want fewer options. The top here in blue are the ones that are most important. But the reason there's these others is you may, in a particular case, want to do something a little bit different. Or if you make an error, you don't want to have to start over again. So this allows, once you're familiar with the workflow, to do individual steps. So, when starting out, I just want to kind of take a look. Hopefully you can all appreciate this part of the brain has high uptake. That's where this enhancing lesion is. I might adjust the MR signal intensity and the color, the scale. And so now I'm ready to start. So here, in all the cases, I'm going to show you the standard lesion analysis. This basically takes you step by step through everything you need to do, but each individual step is here. So if we wanted to do something slightly differently, we could also do that. We have some flexibility. I don't think you can read, but this is basically prompting me to draw the reference contour. And so I have my 15 millimeter circle. If I can adjust it. Sorry, I'm doing it through a remote desktop, so it's a little bit harder than in the real setting. So here I'm just drawing this crescent. Want to go to a next slice. That was a little sloppy, so I'm going to trim it off there. And one more. And so now that that's done, I'm going to resume the workflow. It's telling me that it's going to apply the Sokolov scale. Importantly, it's telling me that the TBR 1.6 is going to be set at the 50%. So if you remember from what I was saying earlier, that's going to be that cyan to green transition. And then if I get into yellow to orange transition for TBR 2.3. So however your workflow works, just know how it's setting the thresholds for the color scale. So you can see now I have this Sokolov color scale. And so anything that is kind of into green is going to be above TBR 1.6. Anything that's above yellow, getting orange and above, is going to be tumor. So this is an obvious case. You can tell automatically there's a large volume of the lesion that's above TBR 2.3. So this is a straightforward case. It's now prompting me to draw a TBR 1.6 region of interest. And what the workflow has done is, I'm going to show you these contours. Again, you probably can't read, but it set the range, the lower limit at TBR 1.6. So my region of interest tool is automatically set to only draw above TBR 1.6. And so I don't have to be super careful. I just need to avoid vascular structures, which here there's really none. And I'm just drawing over this. Now, because this patient has been treated, I'm really mostly interested in the TBR 2.3 in terms of defining tumor. But we can start here, and the nice thing is the workflow can just automatically then apply additional thresholds on top of that. So I'm going to come down here to the lower part and just make sure we're including everything. And I'm going to go through the subsequent cases a little faster. I'm going to show you some examples here. A question you might have is, there is a little bit of higher uptake in the basal ganglia, particularly the striatum, compared to normal brain, just a little bit. And so here's a place where looking at the MR, whether the MR is abnormal, is going to help me. So in this case, I probably would include them. I'm not entirely sure if they're involved, but I wouldn't include the other side because I don't see any evidence that this is crossed over. And as you'll see, these are not going to be included in the TBR 2.3. But again, having the MR makes me more confident. So I'm done. I'm going to resume the workflow. Now it's asking me, do I want to generate sub-thresholds? So I'm going to say yes, and it's going to do a number of things. It's going to generate first TBR 2.3. And so now when I look at these images, here we are with our TBR 1.6. I think it shows best over the contrast enhanced. So this is the area in orange, and I'll make it filled in a little bit. This is area that's above 1.6. If I go to 2.3, you can see it's a substantially lower volume, as you would expect. And this is a good example of a case where actually most of the tumor that's positive on FET is not really in the area of enhancement. And so that would be something you'd want to include in your report. And you can see there's also some lesions that are above the threshold that are kind of away from the main enhancing mass. For those playing at home, that is a meningioma, and it did not have much uptake. Now, the last part of this, in terms of the quantification, is I'm going to generate subregions. And those subregions are going to include our circle. So we talked a lot about how to generate these things, and when I show you the next case and kind of go through it in a little more real time, you'll see that it's actually quite simple. So here is the circle. So this is centered at the TBR max. It's been generated automatically, and we're going to use that to calculate TBR max. The other question it's asking me here is, do I want to display this where I've set the lower limit of the color scale to the TBR threshold? I'm going to say yes in this example. Again, this is optional. I think you can generate some nice images this way. And so what I'm showing here is the MR above, and then below are images where the only color it's shown on the fusion images are areas above TBR 2.3. And so this can be a nice way to display the images in a way that makes it easy to see on the MR where the positive PET signal is. But this is optional. You don't have to do it. The other things in this workflow are I can create a statistics table. And so what it's doing here is asking me, what do I want to set as the TBR threshold? So I want to set TBR 2.3 as the threshold. And the workflow simply displays in red everything that's above TBR 2.3. So I look at my circle, and I can see the TBR max is 3.2, 3.18. That's well above 2.3. This is not a difficult case once you understand how to interpret these. This is a clearly positive case. And you could take a screen capture, you could send this to PACS. You could also modify this to make it a little more simple. This is a little bit of a busy table. I also have some other measures which are not part of standardized criteria, 10 millimeter sphere, as well as an 80% ISO contour, so everything that's 80% of the SUV max and above. But those aren't standard measures, and you might in your clinical work want to just remove those. Or you may say, I want to add something else. You can easily add it. One of the nice things about the workflow is it is very customizable. I'm going to go to the next case, but any questions at this point? All right. And we'll have time for those who want to ask. We can go over things. This is just a screen capture. This was, clearly a positive case, and unfortunately, as you would predict, this patient rapidly had clinical and radiographic progression on MR. So the next case, very similar. This is a right frontoparietal glioblastoma, and they'd had undergone treatment, although I don't have their treatment details. So, you're going to see very similar things. I'm going to load this with our workflow. In this case, it didn't automatically match them, so I simply have to pick the correct one. At your institution, you can set up logic so it will recognize these automatically. All right, so let's take a look at this case. So again, I want to look at the MR and see, where are we interested in. So here's some enhancing tissue. The question is this treatment effect or is there a tumor here? So again, you're going to see a very similar process. I'm going to go a little faster. So now it wants me to draw the reference region. So I want to draw my 3 consecutive slices. Again, that was a little bit off. And so now that I've done that, it's going to apply the color scale. So again, it's going to be the TBR 1.6 is at the 50%. So we're looking for TBR 1.6 to be anything green or higher, and for TBR 2.3, anything orange or higher. And so we can see this is a pretty unimpressive case. Maybe there's a little bit of green in the region of this lesion, but not a lot. I would like to point out, this is not the best example, but in the sagittal sinus, there are some areas that are kind of in the yellow. In this case, it's simple because we're far away from it, but just be aware, the blood pool can have uptake that would be in the range you would expect for a tumor. So in this case, now I'm going to draw my TBR 1.6. I already know that there's not going to be a lot of tissue that's in TBR 1.6. There's a little bit. Hopefully you can see that region of interest drawn there. But, visually, it didn't look like there was much, and the ROI is relatively small. So now I'm going to resume, and I'm going to apply the TBR 2.3, and we actually don't see an ROI because there's nothing that's above TBR 2.3, which is exactly what we would expect based on our visual interpretation. There's nothing that's in the orange. There's not even anything really getting to the yellow. We can generate our subregions still, and I'm not going to show that lower threshold raise. I don't think it helps in this case. So now we've completed the analysis. Visually, this looks negative, and we expect this to be negative quantitatively. So I'm going to create the statistics table. Again, I'm going to use our TBR 2.3 because this patient has been treated in the past. Now we see nothing in the red, and so for our circle, our TBR max, we're at 1.5. Well below a TBR max of 2.3. So this is a clearly negative case. And this was part of a reader study, and not surprisingly, 3 out of 3 readers agreed. Next case, this is a grade 3, so it's a high grade, but not a high grade astrocytoma, but not a glioblastoma. Also been treated. So again, because these are outside studies, at least for me, these don't match up. But again, it's trivial to assign the correct one this way. So again, we're going to look at these images. Looks like I loaded the wrong T1 pre, but that's going to be okay. So here we see an enhancing lesion in the left occipital region, and that's going to be a key area of focus. So we're now going to do our analysis. So I'm going to draw our reference region. And resume. It's going to apply the Sokolov scale. Again, same story. So if it's green or higher, we're going to be above 1.6. If it's orange or higher, we're going to be in the range of 2.3 or higher. So really don't see a lot here. So maybe a hint of yellow, but not a lot. So this is looking already visually negative. So I'm going to draw our TBR 1.6 region of interest. And again, we do have some in that range. So we are seeing a little bit of volume. And then I'm going to resume. I'm going to generate our TBR 2.3. And again, in this case, there is no TBR 2.3 ROI. Just like our visual interpretation, we didn't see anything in the orange, and therefore we don't expect to see a region of interest. I'll generate our subregions, including our circle, and then I'll do our statistics. And here, again, our circle, the value is 1.5. That's well below the 2.3 value that would be considered positive. Our visual and quantitative analysis matches. So this is one that both visually and quantitatively is negative. And again, this was from the reader study. 3 out of 3 readers agree. And so, the first 3 cases I've shown you are fairly straightforward. I'm going to show a couple of cases that are maybe a little bit trickier. So 68-year-old woman, right occipital glioblastoma. Here I don't have as many MR images, but that's okay. And I'll go ahead and load this. And again, as I mentioned, I think MR is very valuable for the interpretation, but it's not absolutely required. But I, do think you want it. But it's okay if you don't have them at the time. You can still do all the measurements on PET only. So here we have our study. So I'm going to run our analysis. And, we're looking in this right occipital region. I'm going to draw a reference. Again, same story. So now the color scale's been set, and we're going to be looking for things above green for 1.6 and above orange for or higher for 2.3. And so in this case, there is a small area that has increased activity. It's clearly above green, and parts of it are clearly above orange. So there are regions here that are TBR 2.3 or higher. And so this is where things get a little bit, this is a case that I think is more challenging because it's a relatively small region. So first, just like in the other cases, I'm going to draw my TBR 1.6 volume of interest, make sure everything that's green or higher is included, so I've got it. Here I know that unlike the last two negative cases, I am going to generate a region of interest that's above TBR 2.3. And so now, hopefully you can see, I think it's best seen on this image. This is the small area that's above TBR 2.3. So it's pretty small. And that's what makes this case challenging. I'm going to go back and generate our subregions. And now when I create our stats table, we're going to again use TBR 2.3 for our TBR max threshold. There are some of our measures that are above 2.3, but those aren't our standard measures. If we look at TBR max, we're just at 1.7. And so this would be quantitatively negative. However, there is clearly uptake that is above TBR 2.3 within this lesion. And you also ask the question, and this is, I think, one of the limitations of this circular ROI. If I look at where our circle is placed, you can see that some of this is outside of brain in areas that on the PET have pretty low signal. And so you need to be careful with the TBR circle, TBR max circle, if you're dealing with something that's close to CSF or has regions outside of the brain like this that have very low uptake, you're averaging the signal with areas that really aren't brain or part of the lesion. And that's one of the limitations of the TBR max calculation with this method. So this is a challenging case. I think it would not be unreasonable to suggest there may be tumor there, but it would also be reasonable to use the quantitation, because not that much is outside the brain, and call this negative. And so in the reader study, this was read 2 out of 3 readers as negative, but 1 person thought it was positive. And so I think this is not just based on the readers, but this is an equivocal lesion. There could be a small area of tumor. And I think one of the things we're going to learn with FET is how do we really want to deal with this? A lot of studies, or a number of studies have kind of looked at serial FET PET, and I think the change over time, or serial MR, is probably what you're going to need. But this is someone who is unlike those negative cases. There is some suggestion there could be tumor. This is probably someone you'd want to do a shorter interval follow-up than you might do for someone who had a clearly negative study. But these will happen, and like all of our oncology imaging, we do see lesions that are hard to classify, and I think this is one of those. The last case I'm going to show you is a patient, another glioblastoma, right parietal. They had been treated with chemoradiation about 6 weeks ago, had completed it, and now we're undergoing PET. So we'll load it up. So here are our images. I'm going to just adjust the intensity scales to get them where I want them. So this patient has an enhancing lesion in the right parietal lobe. So we're going to just run our workflow, and hopefully this is all pretty familiar. I'm going to draw our reference ROI. It's going to set the color scale, and again, same thing. So here we're looking for green as our threshold for 1.6, orange for TBR 2.3. And so here, looking at this image, pretty obvious that there's areas that are well above TBR 2.3. So same story. I'm going to generate my TBR 1.6. This is another good example. If you look at the where I've got this sphere, you can see that there is pretty intense activity in the superior sagittal sinus. So it wouldn't make a big difference in this case, but again, pay attention to vascular structures because in some patients you may see high activity in the vascular structures. So here we have our TBR 1.6. Get a little more up here maybe. And so we know that we're going to see a volume in the TBR 2.3. We can tell visually. I think already visually this looks positive. And I'm going to generate my subregions again. And then let's see what our quantitation shows. But so we have a sizable volume that's above TBR 2.3. So, we're good thinking this is going to be positive. And so our TBR max is about 2.7. So this is a visually and quantitatively positive study. This patient, though, actually was fairly stable over time. And so, we think some of this may be a case where there's a lot of uptake in the inflammation. So there are going to be cases where, the FET PET is clearly positive, but the patient may do well over time. So I show these because, in many cases they're straightforward. Some of these are very clear, but there are going to be cases that are either equivocal and there are going to be some false positives, or at least cases where they don't behave like they have a large volume of viable tumor. So with that, I'm going to stop. I appreciate your attention. I'm happy to answer any questions you might have. So please use the microphone if you have questions. Sure.
Hi, I'm Dr. Nguyen from MD Anderson Cancer Center. Question, the reference you draw is contralateral side of the brain. Has the cerebellum been considered as a potential reference?
So I think you could do that. I think the challenge is there is you just need to make sure you're not near the transverse sinus. I actually think FET, the region of interest, the brain uptake is pretty uniform. So I think you could consider it. All I would say is there are papers out there that have really looked at the reproducibility of this method. And so most of the recent FET PET data does this. I couldn't tell you would get exactly the same TBR values with the cerebellum. But on the other hand, I think one reason this is so reproducible is because the uptake in normal brain is fairly homogeneous. You just need to be careful that you're not including non-parenchymal structures.
And certainly I would like to know from Telix, when do we get it in terms of FDA approval and so on? Because we talk about this and we don't get to use it, or what?
I'll leave the easy question for you, Nabil. No. If you need to, feel free to come up and use this.
Okay, yeah. Yeah, I'm not sure it's an easy question, but so I can say that it's not today, but based on the FDA, that the PDUFA date will be September 11. I know that's not the best date that we are looking forward to it, but it is what it is. And we have our own strategy in the company that once it gets approved, we are gonna start reproduce that and provide it for US as soon as possible. Yeah.
Thank you for your presentation. My name is Piyush Bhargava. I'm from Houston. My question to you is there any guidance so far on when to do the follow-up scan after chemotherapy and radiation?
That's a really good question. And some of the examples I was showing from research are actually the point of the research was to look earlier and see how well FET performed. Hopefully we'll publish that soon. I think generally the way it has been used, and I anticipate the way it will be primarily used, is an MR shows, for example, a new enhancing lesion or some other feature that's suspicious for or could represent glioma. So, that could be as soon as the first scan, if you saw enhancement, but a lot of times people might wait to see if that resolves because it could be pseudoprogression. So, early on, there actually have been some small studies that have proposed higher thresholds, like a TBR 2.5, not to confuse you. But it probably is the case the closer you are to completion of radiation, the more intense activity in treated tissue rather than tumor tissue you may see. So, I think a lot of our scans practically are going to be 12 weeks or more after chemoradiation. If there's a second scan that shows progressive enhancement or some other suspicious feature or a clinical reason. But that's a very good question. I do think those are some of the nuances that once it's more widely available, and hopefully there will be additional studies in a multi-center setting that can establish, do we need to use different thresholds? So I don't have a perfect answer for you. I think a lot of this, though, is going to be driven by equivocal MRI.
Dr. McConathy, as we close today, at midwinter we presented, and when this question came up, so I'll ask it again, what's the acceptable sort of time frame to get an MR versus the PET if you don't have a PET MR modality?
That's a really good question. And so, it's going to depend a little bit on the patient. I think unless something's really very active going on, I think as long as you're within, 3 to 4 weeks, you're probably good, assuming there's not been a procedure, a bleed, or something else. I think ideally they're going to be closer, but probably 4 weeks is going to give you enough guidance as long as there's not been some known interval change.
All right, wonderful. Any other questions?
Right behind you.
Right here.
Hi, Dr. Casey from University of Minnesota. So I have a question. So you were mentioning about it can be used for either questionable recurrent lesions or untreated lesions. So shall we be able to use it to grade a tumor when they come before treatment?
For grading, that is a really good question. And, probably if we got the right people up here, you could have an hour-long argument. It's the case that, in general, the TBR isn't a great way to distinguish the uptake. It is true that higher intense, let's say we have a non-enhancing glioma, because if it's enhancing, most likely, unless it's like a juvenile pilocytic astrocytoma or something unusual, it's probably high grade. But if it's a non-enhancing lesion, it's generally the case that the higher the TBR max or TBR mean, the more likely it's high grade, but it's fairly weak. So using TBR on an individual basis to grade tumor doesn't seem to work. There are people who advocate dynamic scans for exactly that reason you're bringing up. And so if you see very fast time to peak, so very early time to peak on kinetics, meaning fast delivery of FET, lots of blood flow, that suggests you're dealing with a higher grade glioma. Similarly, if you watch over time from that peak, if it actually washes out, that's a sign that you're dealing with a higher grade glioma. And so people sometimes use those, but it's a little controversial as to how well that works. And I do think sort of your technique becomes important. So there is the potential to grade. Most of the data that looks strong is more around kinetic rather than TBRs. Where I would say it's been more useful is making decisions about resection. You may see tumor that was not clearly tumor that is gross tumor based on FET that might involve, eloquent cortex or important fiber tracts. Similarly, there is strong data about using FET to guide biopsy for non-enhancing gliomas in particular. So I think those are strong indications. Grading we'll have to see. That's, I think, a little more controversial.
And I think the other problem is the insurance coverage, right? If this is specifically going to be accepted for tumor versus radiation necrosis, then doing the scan for other purposes might create problems.
Correct. We'll have to see what the label shows. I don't know if untreated glioma will be part of the label. I think, if it's approved and reimbursed for, evaluation after treatment, I like to think we may be able to use it off-label for those indications. The data, especially around biopsy, is actually quite strong.
And I want to add something.
Sure.
And I believe also the reimbursement will be much way easier now, especially last year, the NCCN guidelines, recommended to be used under category 2A along with MRI. So I believe that will help you also to reimburse it, yeah.
Yeah, John, that was a great talk. Really appreciate it. Speaking of September 11th, off-label fluorodopa. Do you have any experience with that? And outside of the basal ganglia, my understanding is it's relatively similar sensitivity and specificity-wise.
Yeah, so in fact, to a first approximation, all of the amino acids that are transported by system L, F-dopa is one of those. Methionine carbon-11 compound has a lot of data as well. They have overall similar performance. The quantitative data is a little bit different for methionine versus FET in terms of the ratios. And for F-dopa, there's not as much data. I was part of a small study when I was at WashU using F-dopa prior to surgery, and I think it performs quite well. The basal ganglia are an issue, although I will point out FET actually has some higher uptake in the basal ganglia than normal cortex. With F-dopa, not to get off the topic of FET, we found that actually if you looked earlier, you could, like 10 to 20 minutes after injection, you typically didn't see a lot accumulating in the basal ganglia. So, I do think, I'm not aware of a lot of places that are trying to do F-dopa clinically off-label. I think it's somewhat a production issue of getting actual NDA-produced F-dopa. But yeah, the data in general for system L tracers, they seem to be more similar than different.
Thanks.
Sure.
All right. Just another question? Yeah.
Hi, my name is Satish and I'm from University of Chicago, primarily radiochemist. But I was wondering if if you see any difference between IDH mutant and wild type tumors in general.
There is some data, and I don't know that people have been able to really distinguish that with FET. There are some group differences, but I don't know that we can say that we can distinguish those two with FET. Maybe someone can, but I'm not aware of a good general method to do that.
Hi, thank you. That was very interesting. I'm just learning all these, and I'm just wondering, have you thought about dual imaging with FET and FAP?
It's an interesting question. So if I was allowed, I'd bore you with a FETF MISO dual tracer. I do think it's quite interesting, the idea of doing dual tracers. There is some uptake. So FAP can be present actually on glioma cells. I think the challenge with FAP is partly we need more data if you were going to propose using it for something like FET in terms of treatment versus tumor. The other issue is all of the FAP ligands I'm aware of don't cross the blood-brain barrier. And so I'm not saying there's zero role, but one of the real strengths of system L PET tracer is your ability to evaluate non-enhancing glioma. So I think it's an interesting research question, and I actually think there's a lot of interesting research questions. Even FET, FDG is kind of an interesting question. But I think the issue with a lot of great oncology PET tracers that work elsewhere, the blood-brain barrier, especially when you're dealing with non-enhancing glioma, is a major limitation.
All right, with that, just one note, once the product becomes available, TLX Med Affairs and Physician Education will provide reader trainings and peer-to-peer engagement on the subject. That will have to wait until the product is approved. But with that, we've extended our time, so we'll thank Dr. McConathy and Nabil El-Fashay. Shafi. All right, thank you all very much for your time and attention.